Good morning, everybody. Thanks for coming to this session. It's one of my favourites of the Congress. We do it most years on safe staffing, and this year we've tried to structure it so we're going to go through the whole issue. We're going to have the evidence, the research, and what it shows us, the policy and the regulatory approach to this, and what the national bodies feel and think and say, and then we're going to have a sort of frontline experience of how this is actually done on the ground. If I can invite our speakers to come up on stage, we have with us, first of all, Peter Griffiths from the University of Southampton. Peter, if you can join us, and Mike and Mark. And we've got Mark Radford, NHS Improvement Nursing Director. And last on stage is Mike Wright, Nursing Director at Hull and East Yorkshire Hospitals Trust. And Peter, I think you're going to kick us off, aren't you? So if you... thank you very much.
Right. Good morning. Thank you. 10 minutes, all the evidence around safe staffing. I realise that the topic of the session doesn't specify any particular staff group and it doesn't specify any particular setting, but I'm going to focus on research linking nurse staffing and patient outcomes, and I'm going to focus on nursing in hospital wards, and I'm going to do that without apologies. It is worth mentioning that there are similar studies on nurse staffing in other areas such as primary care, emergency nursing, intensive care, and specialist cancer nurses. And I think it's worth noting that the issues of staffing levels apply to other professions, that many of the issues that we see here are shared with other professions. And I certainly hope that we might pick up some wider lessons about how we respond to evidence of this type. Which is in effect a workforce epidemiology where we need to make decisions under huge uncertainty which have huge economic implications. I'm also going to focus on evidence around staffing levels. It's a huge topic and there's much more to safe staffing than numbers. I freely admit that. And sometimes it seems like people are searching for a magic number that guarantees safety. Sorry to disappoint, I'm not going to give you a magic number. I don't have one, and I don't think anybody ever will give you one. But we have to start somewhere, and having the right number of staff is a necessary, if not sufficient, prerequisite for delivering care that's not only safe, but also meets the standards of care and compassion that professionals aspire to, and that all of us would expect, our family, friends, and would expect for ourselves. The link between nurse staffing and patient safety was recognised and researched well before the events that led to the Mid-Staffordshire inquiries. But reading the reports, it makes it clear that the link was simply not recognised by many people in the Trust. Or if it was, they felt compelled to ignore it, or felt, for some reason, able to ignore it, with tragic consequences, as we see. And I think one of the positive outcomes of all the inquiries in mid-staffs is that nurse staffing and safety has now become inextricably linked in the discourse of the NHS. So much so that sometimes when we produce new evidence in this area, it evokes cynicism and is dismissed as simply making statements of the obvious. Both the statements on this slide have been uttered in response to publications of new research over the last couple of years. And actually, they've been said about my research, so I sort of own it. But let's put it another way. In 2010, the RCN described evidence linking nurse staffing levels and patient outcomes as compelling. As far back as 2005, the US Joint Commission, broadly equivalent to the CQC, described it as overwhelming. But one of the results of the Francis inquiry was that the Department of Health commissioned NICE to develop guidance on safe staffing. And I'm going to quickly summarise the findings of their evidence review. We undertook this in our team at Southampton, and there is a lot of evidence that says that higher registered nurse staffing is associated with lower mortality. Estimates vary, but a 6% reduction in the odds of a patient dying for every patient, every single patient less that a nurse cares for is pretty typical. The higher registered nurse staffing is also associated with lower reports of omissions in nursing care, fewer falls, shorter hospital stay. There's some more mixed evidence around pressure ulcers and drug errors, probably due to methodological limitations. A richer skill mix, so a higher proportion of registered nurses in the overall nursing team, is associated with reduced mortality and other improved outcomes. But higher staffing levels by assistants, equivalent to healthcare assistants or similar, is associated with worse outcomes. We found no evidence suggesting that higher levels of staffing by assistants improved patient safety. Okay, just not pressing hard enough. It then came as a surprise then to many when NICE came to this conclusion about the evidence. There is a lack of high quality studies exploring and quantifying the relationship between registered nurse staffing levels and healthcare assistant staffing levels and skill mix. So why did NICE appear to dismiss the evidence in this way? Well, our review considered hundreds of studies and focused on 35 that considered elements of skill mix. These studies have been undertaken in hundreds of hospitals, the largest over 600, with outcomes from millions of patients, the largest over 27 million. It's not a volume issue, but few of these studies were without significant limitations. Most of them were cross-sectional studies simply associating average staffing in a hospital with outcomes over a given period of time. Although one important US study showed that individual patient experiences of low staffing preceded poor outcomes. There was essentially no economic evidence to inform decision-making in the UK. So in recent years, the overall pictures in terms of these associations has not really changed dramatically, but evidence is starting to emerge that addresses a number of the important limitations and uncertainties that arose from those NICE reviews. And I'm going to share briefly with you some of the results from our latest NIHR-funded study, which is based on data collected over 3 years from one UK trust, which shows the effect of individual patient-level exposure to low staffing levels. Now, this is a trust where average nurse-to-patient ratios were between 6 and 8 on general wards. The registered nurse skill mix was typically about 60%, varied quite a lot from ward to ward. And what we see here on this graph, which I love, but I know is not necessarily easy to interpret, is that for every additional hour of registered nurse care that a patient experienced over their hospital stay, there's a decrease in the risk of death by 3%. Importantly, the relationship appears to be a linear one. There's no magic number out there. There's no sudden threshold at 1 to 8 or anything. This is a linear relationship over what we have seen. If you put more nurses in, you reduce the risk of death. End of story. For healthcare assistant staffing, though, a different picture emerges. As we move from average staffing in either direction, the risk of death goes up. So this trust has a budget of about £500 million per year. And we use the data from our study to model the costs and consequences of staffing changes. Adding an additional registered nurse hour per patient per day would add about £10 million to that trust budget. That's about 2.5% of their budget. A big increase in RN staffing. But if we look at UK nurse staffing in international terms, our staffing levels are actually quite low. So maybe that's not an unreasonable aspiration. We estimate from the results of our study that for every 325 patients admitted to that hospital, 1 life would be saved if we increase staffing by that much. In total, 219 fewer deaths per year. Higher registered nurse staffing was also associated with shorter stays, and we estimated that that increase would be associated with 11,000 bed days saved. Net cost, about £150 per patient. If we simply tried to staff the trust at the level that that trust had actually planned to do, working with slightly more RNs, slightly fewer healthcare assistants, basically increasing the skill mix, leaving total staffing unchanged, the increased staffing costs would be less than 0.25% of the trust budget. And once the value of the bed days saved are considered, the cost is in effect zero. We didn't model the effect of increasing healthcare assistant staffing for the simple reason that in all of the scenarios, there was increased cost but no benefits. So this is a single site study, but these results are consistent with other international economic models. Now, you might argue that we need to invest more in the community and not hospitals, and I agree. But here we see a way of reducing the demand for inpatient beds by making hospitals more efficient. And now we get to the nub of it. You might also reasonably say we simply do not have enough registered nurses. So this is all very well. And overall, of course, you're right. But as I speak to directors of nursing around the country, not all of them are having difficulty recruiting and retaining RNs. And often those that don't are in higher staff trusts and they're asked to justify their high staffing and skill mix. Well, here is a justification. We're often challenged about this evidence because it's observational. But at some point, we have to start recognizing that we have plenty of evidence. We need to recognize that there is enough here to be sure that this is a causal relationship. And here I will end with a quote from the CEO of tobacco giant Philip Morris, published in 1993. To my knowledge, it has not been proven that cigarette smoking causes cancer. Well, we need to make decisions in the face of this uncertainty. And in doing so, we've got to consider which outcomes are more likely. I know we've got the looming nursing associate, and I'll sort of talk to questions of that. I won't throw up my final slide because it's quite detailed. But there are implications of this evidence for that, and essentially says that unless the nursing associates increase skill mix, then we are going to get worse outcomes at a higher cost. I cannot predict the future, but I do know the evidence that we currently have. Thank you.
Brilliant. Thank you, Sean, and colleagues. And yeah, I'd like to just say a huge thank you to Peter and his colleagues. I know that they've done a huge amount of work in this area, all of which I think is really important to reflect on what we actually need to do practically in terms of delivering safe and effective solutions in staffing. And I really want to kind of go through a little bit around some of the sort of policy that we're working on. Peter really highlighted, I think, a really important point, which is actually that the whole macro workforce picture is one and the same associated. So designing the right effective solutions for staffing versus having enough are really two interesting challenges and two real serious problems. Now, over the last 5 years, now clearly there has been quite a significant growth in overall workforce positions across the NHS, but underlying that is overall demand has increased. We can't get away from the fact that the increasing service demands have led to a growing increase in the level of a range of different professional groups. And within nursing, if we're looking at that individual professional group, we retain quite a significant vacancy position across the NHS. This year, it's come down by about 3,000 or 4,000 to approximately 36,000. The majority of that is mitigated off against the use of bank and agency. But our view, certainly from our perspective within NHSI, is that's not sustainable in terms of what we need to do. Better retention as well as also supply is a key issue. And with that being the backdrop, actually one of the questions I'm always asked is, well, why design improvement resources, guides and guidance when we don't have enough? And the argument for me is a corollary of that, which is actually we should be deciding what is the right and effective solution based upon the best evidence base, not necessarily what we have now and how do we actually deliver the change and the requirements to deliver up against that. From NHSI's perspective, I work as part of a team. Ruth May's Executive Director of Nursing, and I deliver the portfolio around workforce and staffing for that. And we do a lot of work in this space with our provider organisations. It does look at providers rather than necessarily the whole system. But actually what we're learning and what we're doing within the system is having, I think, some really important lessons in terms of how we start to work around effective workforce solutions in lots of different parts of the system and sector. Now, people who do know me know that I won't shy away from kind of difficult questions, and I know one of Sean's will be is, why don't we have legislation? And my answer is, well, actually, that's a role for government and legislators to design, but my issue is how do I look at the best practice in those kind of environments to identify what we could be doing in terms of our policy. And there is a lot of commonality between what we're doing and delivering within the English framework versus some of the ones that I'm really taken by, particularly the work that they've been doing in Wales as an example, which is trying to build in formal processes in terms of delivery, making sure that triangulation across the piece is really important, notably around professional judgment and outcomes, which are really, really critical. The use of acuity tools, actually utilising the best tools that we have available and making sure the evidence base supports is that. Whether that's kind of care hours per patient day or whether that's hours worked, which is kind of the Welsh model, it's really key to make sure professional judgment is absolutely aligned on that. And the most important thing is the triangulation across to outcomes, i.e. what are we trying to achieve, what are the outcomes? Because as Peter's rightly pointed out, there is no magic number. I've seen a number of studies and arguments actually where we see poor outcomes even where we've got magic numbers of 1 to 6, etc. And I've seen great outcomes at different levels. And actually some of the issues are about how do we make those kind of decisions locally. So we set out a programme. It fits within the Leading Change Adding Value framework, looking at the right staff process. We set out with the National Quality Board to design an overarching framework which was redeveloped in 2016, which set out the expectations, particularly of the organisations that actually are delivering NHS services. Really, really key to make sure that they've got the right staff with the right skills in the right place. Now often people say to me, well, that feels quite nebulous, which is actually we know what the system needs to do. But if we're looking at mirroring what goes on, it is imperative that boards take accountability for the services they deliver and having utilises the best evidence they have available to ensure that they get effective staffing solutions in place. And the triangulation is really important. Where we've got evidence-based tools, that is really, really important to use them and use them effectively alongside professional judgment. You know, we know that certain clinical environments they won't necessarily be able to deliver effective solutions because of geography, of setup, about demands. So professional judgment is really very important, but that has to be measured alongside patient and service user outcomes to make sure that those are being aligned and being monitored effectively to ensure that what inputs go in are adequately delivering in terms of outcomes for patients. We set out to develop, and this is very similar to the Welsh model, actually. They're starting to work on their sector-specific programmes of work at the moment, having developed their overarching policy. We were very clear. Now, one of the questions that Sean usually likes to ask me is, so why was NICE stopped from doing the assessment? Well, I can easily caveat that and say it's way before my time. However, NHSI took on the mantle of leading that programme of work. We sat down with NICE and we actually learned from them a lot about their kind of process. So we were very clear about the independence of the chairs. We went out to the system to identify leading professionals who would be able to do that as an independent. They built teams around them. We did independent academic reviews in the aspect of inpatient hospital work. I was grateful for Peter and his team for Southampton. Where we had NICE evidence, we utilised that. I was the chair of the maternity services programme, and we already had a well-established NICE review into the outcomes for maternity staffing. Those evidence were reviewed. The collective group of stakeholders were brought together to be able to come up with a consensus model in relation to what was, again, the safe and effective options in relation to staffing. Each of those have now been published. We were very clear to look at a range of sectors, including adult inpatients, which dominates the kind of narrative at the moment, but actually we've got equally big challenge in things like community settings, in children's services, learning disabilities and mental health. And what is very interesting, and kind of alluding to what Peter identified, is some of the evidence base outside kind of adult inpatient environments is relatively weak. And actually, we need to do a lot more in terms of building the research evidence to support that. However, in the case of developing the resources, there is a requirement, therefore, to look at best professional judgment and advice to support effective decision-making. And that's really clear. We opened this out to complete engagement. So all of our drafts and our evidence reviews were published as per NICE out in the system. We gathered a range of views from organisations, individuals and services. It was hugely, hugely beneficial for us to be able to test out whether or not these would be working in practice, what we could refine, and made a number of changes as a result of doing that. And again, no surprises with some of the questions that come back in relation to, well, why don't we have X? Why don't we have Y? Can we be firmer number on this or not. And we've had to respond quite clearly by saying, well, actually, the evidence and the review by the team did not support that evidence in that environment. However, the process is really very, very key indeed. Now, one of the key things for us as NHS Improvement is taking that, and now they've all been published, is actually about how do we support the system in doing that. Now, it is about making sure organisations use these resources effectively. So where we describe the use of these best evidence-based tools, people are using those in practice. But it's also utilising best practice. We've got a number of organisations across the country that are doing really effective approaches in relation to safe staffing assessment, board ownership and government, actually utilising the best evidence-based tools, and we might hear from one, Mike, in a moment. But it is important to make sure that boards are cited and given oversight in relation to these, and they understand the risks they hold. Now, the risks of not having enough versus the risks of actually designing the right system and monitoring against that standard are two separate issues, and part of our role is to make sure that that is in place. But also recognising that service change and skill mix redesign are really current within lots of planning approaches that organisations and systems are taking. So our role is to make sure that those processes are dealt with a good governance structure and assess that to know where we've got the most appropriate level of risk in the system and what we need to do about that. Now, it's all right, some people will say to me, well, it's all right understanding that kind of risk and where you are, but what are we doing about that? And one of the things that we've activated, and we've been doing now for 18 months, is our safe staffing support team. It's led by a phenomenal expert in this area, Anne Casey, who has been instrumental in developing the Safer Nursing Care Toolkit program. She's designed this assessment process. We've worked with well over 25 organisations, some who have invited us in and said, look, we kind of need some help sorting this out. Would you advise us on the best approach to take? Versus others who have maybe got some challenges in this area, identified through CQC reports or through our own regulatory process. We've got a very structured programme to look from ward to board in relation to making sure that the tools are being used effectively, right up to the reporting mechanisms, and making sure that the outcomes are aligned with all of the requirements we expect to see in that triangulated approach. And that is really, really important. So we've been working with many organisations to do this, and we'll continue to review those organisations until they are content, and we're content that they're making the right effective solutions. And just to finish on something that we're launching this year, which is actually something we're really excited about, developed out of a concept that Ruth identified in. We actually now have the resources, we have some evidence-based tools to start utilising within practice, but actually what we need is to develop a consensus of expertise across the system to be able to use this. We know from our own work there have been a number of challenges where people have been inappropriately using the right tool with the right intention, but just getting it wrong. So the Fellows Programme launched this year is a faculty working with NHSI and Shelford Group, which will develop a level of expertise across the system for them to be able to support individual organisations and their own organisations in the process that I've described today to get more effective solutions in relation to staffing. We'll be launching that a little bit later on, looking for academic accreditation for that journey, and each year we'll build on that until we have a great resource in the system to support all sectors and all types of clinical environment with the best evidence approach and peer review approach in relation to safe and effective staffing. So I'll conclude there and say thank you very much for your time today, and I look forward to the questions a little later.
Mike, if you'd like to kick us off, and I'll just say, Mike, from Hull in East Yorkshire, one of the reasons I asked him to speak is he's doing some really excellent work, and I hope he explains to us how he went to his board and said, I need to close some wards, and they supported him, and excellent. And that's one of the reasons why I invited Mike here today. So, Mike, over to you.
Thank you, Sean. Good morning, ladies and gentlemen. Firstly, my name's Mike. It's my pleasure to be the Chief Nurse at Hull and East Yorkshire Hospitals, NHS Trust. I worked in London for 18 years, and people said to me, where is Hull? So I thought I'd just remind everyone. It's halfway up the country on the right-hand side, and if you go east on the M62 and keep going a bit at the end, you'll come to Hull. Huge hospital, 2 sites, you can see the dynamics there. We're a tertiary centre and also a trauma centre, and we employ lots of nurses and midwives, just under 3,000 registered nurses and midwives as a measure. The first thing I wanted to say is actually just picking up on Mark's point. The National Quality Board guidance is welcomed. I welcome it greatly. Why? Let's not forget it's a product of the Francis inquiry and the Mid-Staffordshire requirement. But I think it helps to protect patients, it helps to protect staff, and it brings transparency where it didn't exist previously. It allows me to take a paper to every trust board in public, detailing exactly where we are with our nursing and midwifery staffing levels and the challenges therein. So it's transparent, it's open to the public, and I welcome that greatly. And nursing, certainly in our organisation, is no longer seen as a soft option for savings as a consequence of this, because it's out there and everybody's looking at it. I don't think it's the case in every trust, and I think some still are challenged in that respect, but I think it has really helped this particular agenda. And obviously, nursing and midwifery staffing levels are scrutinised by regulators and commissioners, and that's the right thing to do as well. So it gives you a framework upon which to report those. I think there are some issues with it, though. The monthly aggregated average fill rates, planned versus actual, I don't think mean anything to anybody unless you're studying it like people like me. I've never had one query since we've publicised these on our websites, and I know many chief nurses who also feel similarly. That said, I think the same could exist with the care hours per patient day unless we use it more judiciously. I welcome the new changes that are coming in this month to that, and I think I want to talk about how we use those numbers in context, because the numbers mean one thing, but it's the context that really matters. So the numbers alone don't say everything they need to. And again, picking on Mark's point, there's no replacement for experience and professional oversight of all of this, because it's really important that you understand the type of services, the layout of your wards, etc. There has been what would seem to, or feels to be sometimes relentless focus on nursing and midwifery staffing, and I think I would welcome a broader look at the greater workforce. We don't have the same for medics or AHPs, and I think that's certainly an area that we need to start to look at. We need to start thinking about what's the perfect team to deliver care, not just nurses and midwives. I've given some examples of why I mean context is important, and forgive these illustrations, but I'm trying to get a point across. So in example 1, scenario 1, we're talking about you're expecting 4 registered nurses on duty, 4 turn up, so you get a planned versus actual of 100%, it all goes green, and you get a tick in the box. That satisfies everybody, regulators and commissioners alike. However, within that, though, only one of those registered nurses is over a year qualified, and the other 3 are fairly new. In scenario 2, you're expecting 4 registered nurses on duty, but only 3 turn up. So that gives you a planned versus actual of 75%, big red cross in the naughty corner. However, what I'd say there is, of those 3, one is a 20-year experience band 7, a 15-year experience band 6, and a 5-year experience band 5. Which team would you like to look after you? Another example of context, and again, it resonates beautifully with what Peter and Mark have said, and we haven't colluded on these presentations either. But this is a recent example from my organisation, and this was a patient on an endocrinology ward for 3 weeks. This patient's now died, regrettably. The patient had numerous risk factors, but got an avoidable grade 3 hospital-acquired pressure ulcer, to my shame. The staffing levels, however, were optimal for most of the shifts during that 3-week period, and when they weren't optimal, they were at what we call minimum safe. The care hours per patient day actual was often greater than the requirement, so the nursing staffing levels were fine. But what the root cause analysis found was actually this was as a result of poor nursing practice. That is equally horrifying, but what it means is the staffing levels were not the reason or not a causative factor in that patient's harm. It was actually around nursing practice and behaviour. So how do we do it at Hull and East Yorkshire hospitals? We do a lot, actually. We comply with the NQB requirements, papers for every trust board, as I've mentioned, and we do our twice-yearly establishment reviews. We report on all of those things, red flags, sickness rates, and all the stuff you can see there. Our establishments are also set at good and evidence-based levels. We managed to get in before they removed the NICE guidance on ED. So our ED was set at the NICE guidance levels, and I've managed to sustain that, so I'm very happy with that. And our wards are set at a 1 to 7 hour enter-patient ratio during the day as a minimum. And we also have 3 supervisory shifts for the band 7s, and we don't always meet that. We meet it probably about 45% of the time, and we have a 21.6 markup for sickness, annual leave, etc. We also have gone full live with e-roster, and I would recommend that to anybody who's got an electronic roster system. Why? Because when you're working with paper systems and part electronic systems, you will not get the full and accurate picture. But the sooner you go fully live, there's no hiding. In addition to that, what I didn't say about that was we'd had to put out some of our ward sisters through bereavement counselling because we had to take away their paper off duties. But trust me, it was worth it in the end, and we started to get some really good results. And I wouldn't go back now. We have what's called a 6 times a day safety brief. I'm going to show you a bit about that in a second. It's led by a nurse director or a senior matron, and that looks across the whole organisation on every ward on a shift-by-shift basis about where we are, where our risks are, and how we might redistribute those risks, and that's why you need the electronic systems. We also have monthly reviews with nurse directors and senior matrons and charge nurses and sisters to look at their performance and quality indicators as well to see what that's showing alongside the staffing data. And I'm going to give you some examples quickly. Apologies you won't see the the detail of these, but if anybody wants to see them, I've got them on my iPad, and you're very welcome to come and see it in action in the Trust. So that's what we call Save Care. It's an add-on to the health roster. It's sometimes known as, we call it the Wheel of Fortune or the Wheel of Misfortune, depending on what the day is looking like. And just to explain what that is, you've got the outer bands, all the different colour bands, represents a ward or a department. And then you've got the inner blue or grey segment. It's sort of grey on there, isn't it? And that represents each of our health groups. And if you click on one of those grey boxes, it drills down. So, for example, that's our surgical health group. And I can see at a glance from any device, Android, Apple, a laptop, a ward-based or office-based computer, what's going on any of the wards. And it's rag-rated, as you might imagine. Green's great, and then amber is it's got some risk or some issues, and red means that we've got a red alert. Again, you won't see the detail of this, but what this begins to show you is at the top right-hand corner, it shows you your planned versus actual care hours per patient day. The black bars at the bottom are using the Safer Nursing Care acuity dependency ratings, and we do those 3 times a day. The beauty of this is you've got all your information for your establishment reviews if you do this regularly. You don't have to do the month's audit, for example. And what I can see from that is that they were short of staff on the early. There's some red dots at the top which tell me that there's some challenges there. Yet on the late shift, they're doing quite well. They've got slightly in excess of the care hours that they need. So you can get a lot of information very quickly about where you're doing well and where your challenges are and where you may need to act. This one is called the red flag screen, and it shows me out of the 54 wards, we've got 3 that are showing red flags. Again, you won't see the detail, but just to show you. So this gives you an example of how you correct that, and this was where we had an enhanced care need. So a patient that was confused and wandering at risk to themselves and of falling, etc., and we needed to put an enhanced nurse in there. We also use insights data. It gives you lots of information about how you're doing with rota processing, planning in advance, unused hours. I'm going to skip through all of these because time's against me, but again, happy to go through any of this with any of you. There's a latest one that's just come out, and this is the new CHPPD. And what that shows you is, interestingly, the black boxes are the planned, and the grey or light blue boxes are the actual. So it shows we're overshooting CHPPD on a number of days already. It also tells you whether you're redeploying your nurses, how many nurses are lent out to other wards versus how many nurses come in from other wards, and that's really useful to help just settle the dust sometimes. So other actions, what else do? We recruit like mad. We have, however, only got 1 university output per year. We're working on that. We've implemented new roles, you can see them, patient discharge assistants, ward personal assistants, hygienists, and nutritional assistants in elderly care, and all of those are reaping real benefits. We've also got trainee nursing associates, and we're about to have more of those, and also I've managed to get the money for 15 apprenticeships to start those on the nurse training courses as well. I've mentioned the monthly reviews, but this just shows the various quality things that we look at. Our fundamental standards are Essence of Care Plus, and a whole host of other things, including insights, Datix dashboard, looking at harm rates, etc. We had our CQC in March. It's really interesting. They told me off for not having enough nurses, and then they commended me for outstanding practice for the way that we manage it. So I'll take that, thank you very much. And those are just direct quotes from the report. So what actions do we take? We move staff. I don't like doing it, and it's very unpopular, but sometimes you have to when you're balancing risk across the organisation. We've ward-based senior nurses. We've suspended hospital at night and outreach, etc. And you can see some of the other things on that list. I've put pray on there because sometimes it does get very tight. Certainly in the winter, I go home thinking, I just hope we don't have 1 more nurse go off sick, or I'm not quite sure what I'm going to do next, and that's the reality of it. Meanwhile, anyway, we're doing lots of work on retention. We're also looking at the perfect team. We've got a 10-year nursing and midwifery plan, workforce plan in train, and you can see the other things up there as well. So my 4 messages as I close are the future supply of registered nurses remains my biggest concern. We don't have enough, and I don't see necessarily we're going to have enough in the short to medium term. I think we need a short, medium and long-term plan for that. The ageing workforce is really concerning us. The Brexit effect we're not sure of, well, we are beginning to see the impact of that, and we're also seeing nurses leaving nurse training, and I think we need to understand that more fully as well. This is my age profile. You'll see the 2 ring dots there. The one on the right is the just heading towards the 55-year age bracket, and a lot of my nurses are taking the special status retirement. And you can see it's what I call the lemming off the cliff effect at the end there. But the second circle shows that we're not replacing them at the rate that they're potentially going off that cliff. So my takeaway 4. The National Quality Board structure is really welcomed, as are the forthcoming changes, but we've got to use them properly. It's not just about numbers, it's about context. Go fully roster if you haven't. I really recommend it, and we can, again, we're happy to show anybody our learning of that. There are not enough nurses. I've touched on that, and we need to start thinking differently about what that means. But don't be afraid to stand your ground. I know some trusts are under pressure, and certainly some chief nurses. There are people who can help, and don't be afraid to phone a friend. Thank you very much.
Thank you very much, guys, for excellent presentations. I hope that was useful to the audience. And I'm going to shut up for once because there's some really good questions coming in on Slido, and they're very practical and really want to get into these. So we haven't got much time, so we'll rattle through. But there's a question here from Carol about, whilst APs and NAs, Band 4s, are proving a valuable asset to our workforce, are they just replacing the ACPs who are moving across the bridge to gaps in the medical rotas? Great opportunities for all, but still leaves a gap in nursing workforce, but now at the higher end of skilled staff. Mark, I know you've done work with HE and NHS Improvement on this. What's your view on that point?
So if you take a step back and look at the whole workforce, one of the things that will keep people retained in practice is having a very strong career framework. So if we don't have the opportunity for people to progress clinically into advanced clinical practice specialist nursing roles, they will look for other opportunities. And my worry and concern is that would be outside health. So I think having a longitudinal career program that does accelerate that, I think is a significant retention benefit into the system. However, I do realise that does mean that some of our expertise does leave some of our clinical environments to go on to undertake that roles, which is why the base of the pyramid of people coming through needs to be strengthened in terms of increased supply and better retention.
Okay, and there's the next question down from Chris is, what do the panel feel regarding HE removing NHS training bursaries for nursing staff, given the importance of safe staffing levels in hospitals? Now, Mike, can I ask you about that? Because you mentioned you've got one university, one output a year. Are you worried about that?
Yeah, I am worried about that, actually, and I think that we have got a real issue here. If I take an example with our local university, the University of Hull, they offered last September 330 training places to first-year undergraduate nurses. 30 of those dropped out before the course started, and a further 40 have since dropped out, largely citing finances as the reason. I know it's not the same in every university, but there are lots that's still having a similar experience. I think I've been quite controversial in the past because I think that we probably should think about resalarying student nurses. They're a national asset, they're a national resource, and we need a national way of supporting them in a different way to other graduates. It's not just about new money as well. There's money in the system. We're all going abroad to recruit internationally. We're employing expensive agency nurses. It may need some pump priming, but there ought to be enough money in the system to redistribute some of this and channel it more into supporting these people to become nurses. And I think it is a real thing that has stopped people coming or staying in training.
Interesting. Peter, can I ask you about nursing associates here? And there's obviously people I've asked some questions on Slido about this. What do we know about the potential evidence for that role?
Yeah, I think it is a classic situation where we have to make a decision under considerable uncertainty because we don't know what's going to happen. We don't have them. But if you look across this evidence base, if you increase the number of lowly trained assistant personnel, outcomes get worse. It's bad value for money. So you put resource in, but you don't get increased outcomes. If you reduce the number of registered nurses, outcomes get worse. Now, there's a space there in the middle that says, well, if the net effect is that we're upskilling the workforce as a whole rather than replacing registered nurses, then there is a window for better outcomes. But I do worry that it deflects attention from the evidence-based solution that we do have, which is registered nurses. I don't think that the current registered nursing training is everything that we might want it to be, but the solution there is to improve it, not to start creating another profession. And I think there is also a worry that in the longer term, the issue we have is a shortage of skilled workforce in the healthcare professions because not enough people are coming forward. Now, we may create an immediate demand for the nursing associate, but I suspect in the long run we're going to find exactly the same issues of recruitment and retention, and we may find that we have deflected our efforts and diluted the workforce.
Mike, can I ask you to respond on this? You mentioned you're getting nursing associates into the trust. You're working with them, but are you worried that you're downskilling your workforce? And is it just a case of, well, someone is better than no one?
Yeah, I think there's a loaded question. I'm really privileged to work with 19 fantastic trainee nursing associates. They are a joy to work with, and they are learning and developing beautifully. I think there is a place for them in the skill mix of the distribution of care on a ward, but I support Peter in that there is absolutely no replacement ultimately for the registered nurse as the supervisor, director and overseer of patient care. I think it's a fine line. I don't think we must, I don't see them as a total replacement at all. I see them as contributing. In response to the last part of your question, I think if I haven't got a registered nurse and I've got a trained nursing associate, I will put them alongside the registered nurses, absolutely. Because what I need is people to deliver care to the patients in beds, not an empty space on the rota.
Mark, can I ask you about this? Because, Mike makes the valid point there's no the substitute for the registered nurse. But we do know there is evidence there have been trusts that have reduced their establishment of registered nurses by the same amount as they've increased their numbers of trainee nursing associates. So that substitution is happening, isn't it?
So I agree both with these statements in terms of the key importance of having expert registered nurses. I want to look at this from a slightly different question. When I was perspective, because when I was a chief nurse, a lot of my staff nurses used to say, there's a lot of work that I currently do that actually I really shouldn't be doing based upon the kind of graduate RN capability that I have. A practical example is we did a complete assessment of individual time. We found in one ward, as an example, 35% of their time was associated with the management of IV medications. And actually what it was actually putting in a pharmacy support officer into that environment that actually reduced that burden by about 50%. Actually, it wasn't about removing the RNs, it was actually freeing up that time for them to be able to use their expertise in supporting better decision-making things. So I think we have as nurses, particularly in certain clinical environments, to take a long, hard look at what we are asking our RNs to do, because I think there is an opportunity for some aspects of what we need to look at is actually getting more RNs with their graduate capabilities in making those complex decisions and organising care. And some aspects can be devolved to other members of the team, as long as the governance and oversight is in place. Now, whether that's registered, is that training nursing associates, whether that is a ban for assistant practitioners, or whether that's healthcare support workers, we need to use the evidence to decide what is the most appropriate model to be able to do that and ensure that the governance and oversight is in place. You highlight some organisations who have made some decisions about that. I mean, the one I know of that perhaps you might be talking about, it turned out to be it's less than 0.05% of their overall total establishment that they made some adjustments on. It was less than one nursing associate.
But we're in very early days for nursing associates. Let's see what it's like when we've got 48,000 of them.
But I suppose my point is directors of nursing up and down the country are making decisions each and every year about changes of skill mix and design associated with service model change. The issue for me is if I'm seeing an organisation changing 25% of their registered nursing workforce for nursing associates, that's a different quantum for a system that actually is doing this on a relatively routine basis. I'm not saying that decision was correct, but what I'm saying is when you look at the overall redesign of services, I can understand why organisations are making decisions, but some of that, even in my own organisation, was based upon feedback from staff nurses. Actually, some aspects of their work could be delivered by others in the healthcare team to release them to do better options.
We've concentrated a lot on nurses, and I know obviously that's the focus of the panel, but I just want to ask the question around medical safe staffing, because I've been really surprised that I can't find research evidence experts like yourself, Peter, when it comes to medicine. So just very quickly, I wondered if we could just all touch on that. Medical safe staffing is going to be the next big thing, isn't it, after nursing?
And ironically, in this country, this strand of research started with a study showing exactly the same findings about medical staffing. And we found that in our own research as well. And it's obvious. On one hand, we've neglected nursing as a safety issue. Well, before we started any of this, surely the obvious group that we might think would be associated with mortality is the medical profession, and indeed they are. So, Yeah.
Mark, do you think regulators are going to be, are you going to be doing some medical safe staffing work?
I know our medical directorate have already done some work in terms of describing what are effective staffing solutions. I know that they're working with a number of the Royal Colleges to do that. I agree with Peter. Some of the evidence is well established, but is quite historical and needs to be updated. But I see it as a composite, actually, as a team, not just individual professional groups in isolation. It's the synergy that makes it work.
Mike, you're a nursing director, but are you having conversations with your medical director around the same issue?
Yeah, absolutely. I'd really welcome that transparency, not just for medics, but also for AHPs. Interestingly, our Chief Finance Officer often says when I present my safe staffing paper to the board, I'd like to see the same for the doctors as well. And I think when we get that transparency, it will also support our medical colleagues. It's supported nursing, so I would absolutely recommend it for medics.
I know we've got the exception reporting tools at the moment, which could become a basis for maybe some medical safe staffing.
Yeah, it's rather reactive though, isn't it?
Yeah.
It's sort of locking the door after the horse has bolted. If you have, with safer staffing, you're looking at it prospectively as well around the future, what you're doing about some of these solutions, and it's generated really good conversations at our board.
Yeah.
I'm very lucky I've got a very supportive board, but I think we need to look broader than just nursing and midwifery.
Yeah, well, sadly we are out of time. I think we could have a safe staffing conference, actually. I really do. But
Good.
and I hope this has been useful to all of you.